Hello, everyone. My name is Gabrielle Altit. I'm a neonatologist at the Montreal Children's Hospital. And today we are doing a case review for the case of the month of September 2025. This is part two. So briefly, this was a preterm infant with prolonged rupture of membrane and anadromia since 16 weeks, who was born and required respiratory support and was in hypoxic respiratory failure. And if you followed echo number one, you saw that there was a physiology of functional pulmonary valve stenosis that was ductal dependent. In case one, we saw that the ductus was wide open, completely left to right, with no output from the RV to the PA. So we had started INO, we had started dobutamine to support the RV function in order to recover and provide forward flow via its antegrade outflow tract. And we maintain low PVR in order to help the RV generate forward flow, as well as to promote blood flow towards the pulmonary vasculature via the ductus. But we had not started PGE because the duct at that point was wide open and unrestrictive. And they would be concerned that with ongoing PGE, we may lead to side effects such as hypotension. But it's very important to keep in mind that at that point, the PDA was important for maintaining pulmonary circulation. And so information was vehiculated to keep the duct open or reassess if ever the patient would become unstable. The echo number two was actually done on the same night and evening to make sure that the duct would be remaining open and to evaluate whether management of therapy was going towards optimization of the clinical status. As mentioned previously, after initiation of the dobutamine and the drop significantly of the mean airway pressure from 16 to around 9 to 10, we saw a significant clinical response with improved oxygenation, improved saturations. So a drop in oxygen demand around 30 to 40%, and saturations in the 90s. Similarly, the CO2 clearance got much better and the acidosis resolved in this patient. So during the next 6 hours, we repeated an evaluation by TNE. So here we can see a parasternal long axis view with some degree of significant TR, and we can see the eustachian valve with one line, which is the umbilical venous line entering into the right atrium. So after this TNE, the line was actually repositioned in the IVC-RA junction. Here we see the parasternal long axis where we can appreciate the RV outflow tract and the pulmonary valve, which is again not showing great opening at the time of this follow-up TNE at 6 hours. When we put color, we see that the valve seems to be remaining closed throughout the cardiac cycle with free pulmonary insufficiency throughout the cardiac cycle. We see this red flame, but we do see the blood flow coming from the duct, which is this red flame inside the pulmonary artery, swirling and providing this blue flow towards the pulmonary vasculature. So then if we go on, we're still in the parasternal long axis view with an anterior sweep where we see again the pulmonary valve, so RVOT pulmonary valve MPA. And here we can appreciate how we don't see the leaflet open and close. And this is a view with a dropped Nyquist to 77 to again try to visualize. We see when we go quite anteriorly that the duct is here and fully red, so left to right. So here we are in the short axis. We can briefly see that the pulmonary valve opens at time, which is slightly better than the previous scan. So although on the previous clip, we didn't see it open, on the parasternal short axis view, which is a cross section of the other view, we can see it open and just for a brief period of time. We again see the UVL crossing almost the foraminal valley and going into the left atrium, which is here. We see the aortic valve, which opens and closes, and we see the right coronary artery. As we go and sweep down, we see that the function of the LV is good, and The RV does not seem to be dilated at that point, probably because it's still able to empty its ejection fraction via the TR, the tricuspid regurg. So that brings us to the four-chamber view, where we see this right ventricle and we see that there's significant TR. And so this tells us that the RV kind of still has an important fraction of its blood flow going backward and probably entering into the right atrium and eventually emptying into the left atrium. So here we see the LA filling, which looks adequate. We can appreciate also the coronary sinus in the background, which looks of good caliber. That sometimes is an indirect indicator that the RA pressure may be slightly increased, knowing that there's a lot of TR, so that can increase a bit the RA pressure and eventually dilate a bit the coronary sinus. But when you see a larger than usual coronary sinus, you should also always rule out that there's no left-sided SVC draining into the coronary sinus or any pulmonary veins draining in the coronary sinus, which was not the case in this particular patient. So here in the apical four-chamber, we're doing an anterior sweep. First, we see the LVOT, and then we see the RVOT coming out of the RV, and they're crossing, so they're not parallel vessels. Here, bicolor, we see nice flow entering the left ventricle in red, and eventually blue as it goes through the left ventricle and swirls into the LVOT. And then here, we're doing an RV three-chamber view where we see the posterior wall of the right ventricle, anterior wall of the right ventricle, and we see in the middle the aortic valve. And we have the cursor at the level of the RV outflow tract and pulmonary valve, which looks thin-walled. When we do put color, we see that there's a red flame here. This initial red flame is the pulmonary insufficiency, and the bigger red jet here is actually the jet of the duct feeding into the pulmonary artery and eventually feeding into the branch PAs. Here we're getting a ductal cut view, so we can see again that this was something we wanted to monitor throughout the evolution of this patient to make sure that the duct would not become restrictive, as the pulmonary circulation at this point is dependent on the ductal flow. So we can see the arch, we can see this red jet, which is the ductus, and seems to be a similar size than the left pulmonary artery, and then provides blood flow inside the MPA and eventually distributes to the RPA and LPA. And we see in the background the flow into the aorta. So this duct is unrestricted and left to right. We'll see that it's unrestricted on the Doppler profile. So here we're aligning ourselves into the PDA to get the Doppler flow. We can see also the branch PA where there's blue flow going towards the pulmonary circulation. And we have dropped the Nyquist in order to visualize our pulmonary veins. So here in subcostal, we can see that the interatrial septum is still aneurysmal and going from the right to the left. And that's partly related to the significant TR, which seems to feed the blood flow from the right atrium to the left atrium. We can appreciate here this right to left shunt at the atrial level, which is still providing some systemic, still sending some hypoxic blood into the systemic circulation. Okay, here we're doing bicaval view, so short axis in the subcostal window. We see the spine here, the descending aorta, and we have here the right ventricle in the background, the aorta. Here we can see our view from the RV to the RVOT to the pulmonary valve to the pulmonary artery. And in this particular view, which here we're zooming on it to try to see the pulmonary valve, we can see that there is some potential blue going away from the probe. So the RV is generating some forward flow here, but it's still unclear whether or not it's able to cross or to generate sufficient flow and pressure to cross the pulmonary valve and eventually feed the pulmonary artery. So here we are obtaining a Doppler through the pulmonary valve from the parasternal views, where we see that there's some degree of pulmonary insufficiency, and then When we're better aligned in diastole, we see that there's a PA-RV gradient of 34 millimeters of mercury. Although this may be contaminated a bit by the ductal flow. Here's when we get TR, where we see that the TR is close to 29 millimeters of mercury of RVRA. But as we mentioned in previous video, if the RVOT is unable to open, there's no pressure equalization across the RV and the PA, and so the TR represents the RV systolic pressure, but may not necessarily represent what's happening downstream into the pulmonary artery, which is being fed by the duct. Here we can see our shortening fraction, which was calculated to be within normal limit. The TAPSE was also adequate for gestational age, which is marker of RV function. But if you remember, if the RV has significant TR, it obviously pumps backward and its longitudinal function may appear preserved, but it's because it's pumping against the very low afterload right atrium. Here, we're measuring the VTI of the LVOT, which has improved. So it could be secondary to the dobutamine that was introduced as a treatment, as well as improved pulmonary venous blood flow coming back to the left atrium, since we dropped our mean airway pressure. So improving the pulmonary blood flow with the fact that the duct is open and that potentially there's a bit more of antegrade flow through the RVOT. Here we see that's actually a three-chamber view of the RV. So you see the pulmonary artery, you see the atrium here, and you see the aorta with the body of the RV. And we're obtaining a cursor that is just at the valve or below the valve. And we may see a bit of antegrade flow here just after the QRS going through the RVOT, but definitely the situation is still of a physiology of functional pulmonary atresia. Here we're obtaining a pulse wave Doppler at the PDA level. So we saw that it was left to right. And here with the velocities, you see that it's completely positive, except maybe for a brief portion that is right to left occasionally, so intermittently. Because if you're looking at the rest of the cardiac cycles, there might be some here, and some here that are right to left, but mostly really we see that it's left to right flow through the ductus arteriosus. We can appreciate here that the flow through the LPA, the Doppler velocities are showcasing a very rapid upstroke, and some of this mid-systolic notching. So this is, of course, of concern that downstream there may still be a high pulmonary vascular resistances, and we see the similar profile at the level of the right pulmonary artery here. Then we see some pulmonary venous flow. So we have very narrow peaks from the pulmonary venous return. So here we're Dopplering a few of the pulmonary veins. So one pulmonary vein, another pulmonary vein here. And then here we're obtaining the descending aortic flow in the subcostal view where we see blips, but we don't see clear retrograde flow in diastole, telling us that right now this PDA is not significantly stealing from the systemic circulation. And then finally, we're better aligned in the subcostal view where we see the RV, pulmonary valve, PA, and then here we're obtaining a pulse wave Doppler. You see the two lines and you see PW. And here you can see that clearly we're demonstrating that there is actually some degree of potential forward flow at times. Although I suspect that a lot of the velocities we're obtaining might be from the swirling from the PDA. And the reason I say that is that we see the QRS here, and then we see that there is pretty much positive flow. So it means flow towards the valve. So that's kind of the pulmonary insufficiency. And then in the later portion of the cardiac cycle, that's when we start seeing the blue velocities, which are probably the velocity coming back into the PA via the PDA. So I don't think this is that there is any clear forward flow from the RV to the PA. So I'm going to go back and then we're going to go see now the case number 3. The echo number 3. So this was the echo performed a few hours later by the cardiology team to make sure there was no structural heart defect. All in all, we see a parasternal long axis with good contraction of the LV, no clear mitral insufficiency. There is good opening of the aortic valve with good flow through it. We can see in the posterior view that the umbilical venous catheter is still a bit too far. So this was again readjusted. We can appreciate again the TR from the posterior view of the parasternal long axis. And then here we can see that now that we're a few hours old on dobutamine, the pulmonary valve opens much better. So we do have some opening of the pulmonary valve, and there's no obstruction at the RVOT level. And we can see again that this PDA is coming in and providing probably most of the flow because despite, so here we're at a high Nyquist and we don't really see clear blue flow being generated before the valve, but there is opening of the valve. So this velocity being generated prior to the valve might be at a lower velocity than what's coming via the duct. We can also see some of the pulmonary venous flow kind of translating here. And the fact that it's at a Nyquist of 90, it tells me that a few hours later, there's probably more pulmonary blood flow. So we're going to go here. We see again that the valve is opening better than previously. We see the duct nicely here, which is about the size of the LPA, and we see that it's continuously left to right in this view. Here we have the Doppler pattern where we see that it's low velocity and unrestrictive, so very pulsatile. And you can see its measurements at 0.16 centimeter. Again, this is flow. Finally, we see now at 0.4 of Nyquist that we see very well 1 and 2 pulmonary veins and a bit of the red here pulmonary veins, so at least 3 pulmonary veins that are flowing nicely. Here it's the Doppler of the right pulmonary artery, which looks very similar to previous with this kind of mid-systolic notching outlining that there might be downstream high PVR. And then similarly in the background, we obtain the LPA Doppler. Here they're doing the sweep in short axis, where we see that LV function is relatively good. We can see with color that there's TR here that we obtained from the sideline. We can see it here as well as we're doing the sweep. Finally, this is the aortic arch, which looks normal. There's no obstruction. The PDA is seen coming here. And then finally, here we are in the apical view. So we have the apical four-chamber, the LV, the RV, the RA, the LA. And we can appreciate RV function and LV function, at least objectively, looks good. But obviously, this is very difficult to saturate if there is a lot of TR because the RV might be pumping backward against a low afterload right atrium. We can kind of appreciate still this aneurysmal interatrial septum coming and bulging towards the left atrium. Here we see the LV and LV outflow track. We can appreciate a bit on the sideline some of the color of the TR, but we can see that there is really a trace mitral insufficiency, which could be categorized as physiological, with no clear dilatation of the LA or the LV in the context that this is a big left to right PA. Here we can appreciate that there's very significant TR, and when measured, it gives us an RVRA of 28. So now that the pulmonary valve opens a bit more, it tells us, is a bit more informative about RV systolic pressure being similar to the systolic pulmonary arterial pressure. But in the case of this significant TR, there may be high RA pressure, and so knowing that this is a gradient, if we're adding like 5 to 10 of RA pressure, we're around 37 to 40 of systolic pulmonary arterial pressure and or RV systolic pressure. Here we have a 5-chamber view where we see the LV, LVOT, aortic valve, and aorta. We see there's nice flow entering the LVOT cavity. And then finally, when looking anteriorly, we do see that the pulmonary valve opens and closes, and we can appreciate that there's some blue flow being generated before the valve, going through the valve, and with still the PDA being open and feeding. So at this point, there's more antegrade flow in this patient, but the RV has not completely recovered with significant TR. And there's no signs right now that this duct, despite being large and left to right and pulsatile and unrestrictive, that it's being, leading to left-sided dilation of the cavities. And so at this point, it was judged that it was important to maintain the treatment and to monitor closely the patient. Here we see the situs. We see that the situs is appropriate with the IVC connecting to the right atrium and on the right side of the aorta. So the aorta is just here. We can see here nicely that the umbilical venous catheter is still too far and crossing through the foraminal valley into the left atrium. So this was pulled later. Here we're obtaining the spine with the view of the aorta. Here we can see this aneurysmal interatrial septum that is bulging from right to left, and we can see that there's still significant TR feeding into the left atrium via the foraminal valley. These are the views from the subcostal where we see nicely the LV, LVOT aorta, and then finally the view as we go anteriorly, and we can see the duct feeding into the pulmonary artery. We see a bit of pulmonary insufficiency, but we do appreciate that the valve is now opening and closing with a positive forward flow. This is a short axis view or bicaval view where we see the SVC feeding into the right atrium. So there is forward flow coming from the SVC, and we see that the IVC is fluctuating in terms of its size with the respiratory cycle, which tells us that if it was like of a fixed caliber and very distended, that the RA pressure would be very high. We can actually appreciate the line really going too deep in this particular cut. And we can see the flow coming from the IVC. There's a eustachian valve here, and then going into the right atrium with a bit of the TR at times from the tricuspid regurg. And then in this view, which is a really good view in the subcostal region to evaluate the RVOT, we can see clearly that the pulmonary valve is opening and closing. So that's pretty much for this review. Basically, at that point, we were on 30% oxygen, weaning our respiratory status, and the plan was to repeat a TNE the next day in order to evaluate what to do. Also, at that time, the blood pressure were within normal, the lactate was good, and CO2 clearance had normalized. So the decision was made to start titrating and weaning off the dobutamine because the RV had, to some degree, recovered with more forward flow through the RVOT. And the next day, we were asked to reevaluate the patient. So I'm going to go to case 4. So at that point, the saturation was 98. We had normal blood pressure by arterial line, so a peripheral arterial line had been placed. And the patient was still on INO, but the dobutamine was completely off. So here we see RV and the LV with a nice juicy LA. And you can see that now the the interatrial septum is actually flapping towards both sides, both the right and left atrium. We can see that there's still some TR, but it's not reaching the roof of the atrium, and the RA looks slightly less dilated. And so there is still some degree of tricuspid insufficiency, but not as prominent as previous. We can also appreciate that the LA looks slightly more dilated. And now we can see clearly the pulmonary venous flow coming back to the left atrium, despite a Nyquist around 77. So here we're obtaining the E-on-A for both ventricles. We can see that the E is slightly lower than the A, which tells us that at this point, if there was torrential pulmonary blood flow due to a duct, we would have expected a reverse of these waves. The reason is that when you have a lot of QPQS, the LA becomes very filled, and so the velocities typically will increase at the early phase of the diastolic portion of the cardiac cycle, because the LA pressure being kind of, very distended at the end of ventricular systole. When the mitral valve opens, there's a huge gush of flow from this LA to the LV, which creates a big acceleration. So at this point, we have, E that's slightly lower than A, or almost similar to the A velocity. Our TR is around 32, so it tells us that RV systolic pressure are rising. And so at this point, knowing that the PDA you're going to see is unrestrictive, we know that our blood pressure is between 31 to 40, depending on where we're obtaining it. And so this tells us that we're around isosystemic PA pressures, which makes sense because if you have a big duct, you're going to transmit pressure through it. And it's really the direction of the duct that informs you on the PVR to SVR relationship. So it's not surprising to see that we have isosystemic PA pressure or near systemic PA pressure, because the PDA will act to make the PA systemic by transmitting pressure from the aorta to the pulmonary artery. Now, the TAPSE was within normal limit for age at 0.5 centimeter. Here we can see that we have a good blood flow coming back via the right upper pulmonary vein. We have good function of the LV and the RV, and then we can see the velocities here of the pulmonary veins, which are present but not increased. So it would have been dramatically increased when there's torrential pulmonary blood flow via duct. Here we see LVOT with LV, mitral valve, with flow going through it and good left ventricular output. It was estimated around 250 cc per kilo per minute, probably because there was more and more pulmonary blood flow coming back to the LA and to the LV. And then here we can clearly see that there is a trace pulmonary insufficiency, but blood flow is originating below the valve, going through the valve, and feeding anterograde forward the pulmonary artery at a Nyquist of 77 centimeters per second. And when doing a Doppler just below the valve, we can clearly see that now there's forward flow in systole with the closure of the pulmonary valve here. So there is definitely, the RV has recovered and is able to generate forward flow in this particular patient at that point. Perfect. Now here we're looking at the pulmonary veins. We see 1 and 2 pulmonary veins with a pretty much normalized Doppler of the pulmonary veins, although this patient at this point was still on the jet ventilator. So sometimes we do get a bit of artifacts from that, which can translate into little motion in the Doppler. And so the D wave velocity is not significantly increased, which is something we would have expected in a situation of really torrential PDA flow. So we have other Dopplers of the pulmonary veins, and then here we can see again this PDA, which is about the size of the LPA, which is red and which looks completely unrestrictive and completely left to right. So we have the arch, we have the pulmonary artery, and we have blood flow that is red coming towards the pulmonary artery. This is when we do the Doppler, where we see that the velocity is very low, only a gradient of 1 millimeters of mercury. So this duct is completely unrestrictive and is low velocity with diastolic velocity near 0. And it's completely positive, so completely left to right. So we have a left to right pulsatile unrestricted duct that is transmitting pressure and flow into the pulmonary artery with a situation where there's been a recovery of the right ventricle and forward flow through its RVOT. Now, at this point, you want to see, well, are there some signs that the QP to QS is increased? And of course, with left to right PDA, if at the level of the PFO, we have decreased the amount of magnitude of the right to left shunting that previously was occurring, then this PDA might be actually now leading to increased pulmonary blood flow. So here we can see that there's actually, and I've put a bit of a highlighting, but it's a zoom of this view. We have the arch here from the suprasternal view, and we're obtaining the flow in the descending aorta that is postductal. And here you can appreciate that in diastole, so just before the QRS, you have a hollow diastolic retrograde flow. So it informs us that during the diastolic portion of the cardiac cycle, there's a steal. So we know that now the PVR are lower than the SVR, just based from the directionality of the duct. And we also know that there's an actual portion of the cardiac cycle where there's significant retrograde flow from the systemic to the pulmonary circulation, which is not something, that is ideal. The other thing is that we can see here that the Doppler in both the LPA, which is here, and the RPA, which is here, has an increased velocity. And so if so it tells us that there's increased output to both branch pulmonary arteries. With some degree of diastolic extension in the LPA, telling us that during diastole, the PDA is also providing diastolic flow. So we have not yet any signs of dilated left-sided cavities. The LA doesn't seem to be dilated. The LV doesn't seem to be dilated. There's opening and closing of the pulmonary valve that is clearly seen, even in B mode. Here we can see it open and close. And then we go to the subcostal view for important information, because previously we had a continuous right to left shunting at the atrial level, which was making our baby blue. And so when you have continuous right to left shunt at your atrial level and continuous left to right shunt at your PDA level, your QPQS might be actually 1, because you have 1 or less than 1, depending on if the volume at the interatrial shunt is much higher than whatever is going left to right at the PDA. So if your right to left at the atrial level is a higher volume of right to left than what the volume is at the PDA level of left to right, then obviously your QPQS is less than 1. If the amount of right to left at the atrial level is similar to the amount of left to right that you have the PDA level, then your QPQS is near 1. And when your left to right PDA shunt is much more than whatever fraction of right to left you have at your ASD level, then your QPQS is much more than 1. And often you'll see that with your saturations. You'll get this information with your saturation, because the volume of oxygenated blood coming into the LA from the pulmonary circulation is going to be much more in terms of a fraction than whatever is able to pass from right to left at the interatrial level. And so your patient will be well saturated. That's the most common situation. And so here, what we can appreciate compared to previous, where it was a strict right to left PFO, now we see that it's actually bidirectional. And I've actually froze it for you. So you see that it's that it's left to right. So that's the right atrium, left atrium, and it's red. So it's going towards the probe. So from the left atrium towards the right atrium. And then here it's blue. So from the right atrium towards the left atrium, because when flow is going away from the probe, it appears as blue. So it's going in this direction. You can see some of the liver here. And here you can see it when it's actually in motion. So liver, you have some of the lungs on the side artifacts, right atrium, left atrium. Whenever it's red, it means it's coming from the left to the right. Whenever it's blue, it's coming from the right to the left. So compared to previous, now our patient has a left to right PDA and a bidirectional interatrial shunt, and is saturating very well. And on top of it, has some degree of retrograde flow into the descending arch, but there's not yet other signs of PDA significance, like the E on A is appropriate, the D wave of the pulmonary venous return is also within adequate limit. There's no dilatation of the left-sided cavities. So we have signs that this duct, which was previously life-saving for pulmonary circulation, is now potentially going to go towards a phase where it is mostly stealing and increasing pulmonary blood flow. Here we see the descending arch in the subcostal view with the spine, and I just wanted to show like some of the end organ Dopplers. So here we're doing a Doppler at the level of the superior mesenteric artery, where we see that there's continuous flow throughout the cardiac cycle, so no retrograde flow and no absent end diastolic flow. And here we're doing it at the celiac, where we can see that there's flow throughout the cardiac cycle that is forward. And then finally, I put a still frame that shows the pulmonary outflow tract nicely opening with blue blood originating below the valve, going through the valve, and feeding into the pulmonary artery. So basically, at that point, at 48 hours, with the drop of mean airway pressure, with the careful monitoring that the duct would not close, with the introduction of a pulmonary vasodilator like INO, and with the support of the RV function that has now been rescued with dobutamine and has been weaned at the time of this fourth assessment, we were at a point where the physiology had been rescued from a standpoint of functional pulmonary valve stenosis. And the next step was to actually aggressively wean the INO, because at this point we felt that with desaturations in the clinical picture and the TNE, we were starting to reverse the physiology. And so actually INO was completely weaned, and this patient tolerated this very well. And there were other follow-ups after that, but basically I'm going to show 3 weeks later, we were asked in TNE to do a follow-up of the situation. And at that point, this patient was on CPAP of 7, 30% oxygen with normal blood pressure. And what we wanted to make sure is what was happening to the duct, because in our unit, we don't give medication to try to accelerate closure. And we wanted to make sure that, this was not a situation where this patient would need the duct to maintain pulmonary blood flow, as well as to follow the situation of the RV function and pulmonary valve. So here I'm putting a view of the short axis where we can see the RVOT, and we can still see that this pulmonary valve opens nicely for forward flow. So it's clearly a right ventricle that is able to generate sufficient output and pressure for feeding the pulmonary artery, even 3 weeks later. And then here you can see that the duct is actually very small. It looks like a very, like a little flame, very restrictive in its pattern. Here we see the arch view. So first of all, I'm showcasing in the arch view that we have no retrograde flow in the postductal aorta. We see very nicely that there's forward flow. And then when we obtain a Doppler, we see that it has this continuous sawtooth appearance with high systolic, peak systolic and diastolic velocity, which informs us that this pattern is quite restrictive. And so this duct at that point is not transmitting pressure, and it's probably very limited in terms of the amount of flow that it's transmitting from the aorta to the pulmonary artery. It's completely left to right because it's red. So at that point, being very tiny, and we measured it at about 0.1 centimeter, and with forward flow from the RVOT to the PA via the pulmonary valve, and with a very tiny duct contributing to the pulmonary blood flow, we said that this physiology was definitely not ductal dependent, and that the entire clinical picture had been rescued. Here we see nicely in the sweep from the LV2 chamber to the RV3 chamber that we have nice opening of the pulmonary valve and good function of the RV with good filling of the RV. And this RV does not look hypertrophied, which is obviously something you look for when you have patients with concern for RVOT obstruction. Here we had a TAPSE at that point that was around 0.7, 0.65 centimeter, which was normal for the postmenstrual age, with a very thin RV that was getting filled nicely, RA that was not too big, with normal LV function. Here we see the filling into the from LA to LV and from RA to RV with really a trace tricuspid insufficiency compared to what we had previously. We see here nice flow feeding into your LV, which doesn't look, dilated. There's a trace mitral insufficiency. And then finally, we're showcasing again the view of the RA, RV, and eventually pulmonary artery that you see in terms of what we call this TET view or this RV3 chamber view, with a very nice Doppler just below the valve, giving us an RV output around, I believe it was 220 cc per kilo per minute. So basically, for this case, the goal was really to show how dynamic these presentations can be and how they evolve through time. And so it started with a patient who had a physiology of functional pulmonary valve stenosis with almost near no output through the RVOT that was treated with supporting the RV function by anotropy and dropping the PVR using a mix of oxygen and INO. Eventually, we were monitoring this patient to make sure that we would not need to introduce PGE to maintain the duct open. And clearly, the patient recovered with these interventions, as well as dropping the increased afterload on the RV by adjusting our mean airway pressure. Eventually, the dobutamine was weaned, the INO was weaned, and then clinically the patient quite improved and eventually got extubated. was placed on non-invasive respiratory support. And on final follow-up, we saw that the duct was almost closed, restrictive, and not contributing to the pulmonary blood flow that much, telling us that this physiology has been rescued. I hope that was useful, and I welcome comments or questions. And so you can definitely put any comments or questions you have in the YouTube channel, or you can send me any private messages via the contact us button. Thank you for your attention. I hope this was useful in terms of an educational opportunity.